So why do we care? Why do we even want to talk about the vestibular system today? They did a study, this guy in Japan did a study where he had a bunch of people come in with headaches and dizziness and just really bad equilibrium problems, and they were known for that, then they died from whatever reason. Then he went in and had permission to do an autopsy study on the anatomy of all the, I think it was like 50 bodies. And what he found was that in the textbooks, your semicircular canals, these things right here, they all show these things at 90 degrees. And that's the way they've always taught it. And this guy said that not one person, I think out of 50 people, one person had their semicircular canals at 90 degrees. A lot of them went up to like 111 degrees. And if one's 111, the other one's going to compensate and be smaller than 90, so like 78 degrees, 111, 113, whatever. And that's a huge problem because this 90, 90, 90 is perfect. So I'm sitting straight ahead, my head's straight ahead, my eyes are straight ahead, and my vestibular nuclei are sitting straight. Think of like when you go to Home Depot and you put like those balance things on like wood if you're like hanging something. It's supposed to be straight. But what happens is, let's say all these are firing at the same velocity when you're even. If they're uneven, and it's an anatomical problem, it's not like physiological, you're just born that way. One side's going to fire more than the other side when your head's at neutral. Does that make sense? Okay. So if that's the case, then your spine has to compensate for that and give you a little bit of stability because your brain has to know where you are. So if your vestibular system anatomically is saying, hey, we're spinning left, and then your body's like, oh, we're spinning left. Oh, we're not spinning left? Let me check. So then your spine has to kick in and basically give you hypertonicity or subluxation in some of these people to basically stabilize your neck. And these are the people that come in and say, yeah, I've got this really tight neck, right? And then you adjust them, and because you lose that stability in their proprioception, they get really dizzy and they get worse. Because now, anatomically, this is still messed up. So you go and adjust them, their neck's good, their neck's moving, they have nothing to block that bad vestibular system, and now they get dizzy. And now their eyes get messed up because their eyes are just going to go with whatever the vestibular nuclei are saying. If the vestibular system is saying, hey, we're going left, your eyes are going to start to go which way? Right. Because if I go this way, and I'm looking in the back of the room, if I go left, my eyes go right. Right? So then you're starting to, if let's say my left vestibular nuclei is firing too high, I'm going to see flexion on this side. No, excuse me. I'm going to see extension on this side, flexion on this side to bring me back to normal, and my eyes are going to go right. So guess what you're going to see? Subluxation cervically. Okay? So that's something to check, because unless you do these things that we're about to do to correct the vestibular system and to correct, let's say it's vertigo or let's say it's other these things, you can hack them on all you want and you can adjust them as many times as you want. You can make them worse. You know what I mean? And they're not going to come back. And that's the other thing, is a lot of chiropractors too, they'll adjust and they'll say, okay, you're good. And that patient won't come back. And they're like, check, that's success. Like, we're good. And they just didn't come back because you made them worse. And they just didn't check up on them. You didn't be like, hey, you got better, so you didn't come back, right? They're just like, that didn't work for me. I don't know what just happened, but now I'm dizzy and now I've got headaches and I'm not going back there. So then they resort to going to an MD and they've got to get on some some medicine for vertigo. They've got to get on all these different things, and it's because they didn't check for some of this stuff first. Sometimes if you do chiropractic, you just started on something that's like third or fourth on the chain of events in their body when you didn't start with the first thing. Clear that. It's like working on the shoulder when you didn't check the wrist or you didn't check the thoracic vertebrae. You know what I mean? Alright. We'll get to the fun stuff, I promise. Alright, so vestibular effects on autonomics. So...
Hey Jason, can I say something?
Yeah.
One of the studies, since you're talking about vestibular system controlling head and neck movements, it was looking at cats with and without visual input and dropping them in different ways and just recording how that vestibular input on sudden changes, how that directed their head movement with and without visual input. And it talks about in the paper how voluntary movement kind of overrides that reflexive pathway. That's why it allows you to look down, lean down and look at something, even though my vestibular system is saying, whoa, keep your eyes up the whole time. So we're able to override these pathways voluntarily, but they're still there.
That's called a riding reflex. So like cats, if you like throw them up in the air, they're like always gonna land on their feet. You know what I mean? When you're like a kid, and especially like little boys, will like try to mess with cats. And like just kind of pick them up and like toss them because it's fun because they always land on their feet. So you try to get them to not land on their feet, right? You're not trying to like hurt them. It's just like a fun little game. They have that. It's called a riding mechanism. So they always know which way's up and which way's down, so they can always land. And we have something similar to that. We already kind of explained that. Let's talk about this too. People with anxiety. They did a study, and I have a study that was talking about people with anxiety. They looked at their vestibular systems, and their vestibular systems were always off. And it makes sense because if you always feel like you're falling, even subconsciously, you're going to have that feeling of uneasiness, right? It kind of makes sense. So if you've got a vestibular nuclei that's firing on one side, a vestibular system that's firing on one side, you're going to have that feeling of like all the time. So stuff like depression, stuff like anxiety and stuff like that, just because they think it's depression, you can kind of look for stuff that's either biomechanical or physiological and kind of like, it's not like you're saying like, I can cure anxiety. You can't. Maybe you can. But it's stuff to like check out, because if you do see a patient with anxiety, you're like, all right, I want to check something.
There's a 2004 study in New Zealand, and they found a correlation with patients with vestibular damage and anxiety, also with agoraphobia and depression.
Interesting stuff. Vision. I'm going to show you guys a video in a second, and you guys tell me if you guys think it affects vision or not. Vestibular effects on your adjustment. Okay, so the first 5 weeks we talked about how to tone down an adjustment. Last week we talked about a way to boost your adjustment. I'm going to give you guys one more today. Okay, so can I have a volunteer? Thanks, Tyler. All right, so we know that the cerebellum and the vestibular system work hand in hand on the same side. So if I want to do something to, let's say, so lay down, Tyler. Face up, super. Let's say I want to do something to boost his adjustment, and I want to give him on the left side. Okay? So I'm going to come down. And if I know that the vestibular system goes right into the cerebellum, feeds into the cerebellum, and gives it a lot of juice, before I do like a left cervical, before I do any left, whatever I want to do, I can just pick up his head, close your eyes. And then come in and fire. Okay? All that's going to do is it's going to make the cerebellum fire at a higher gain. So when you adjust them, it's going to be a stronger adjustment. Something might hold better, especially if it's vestibularly linked. Okay? So I know we've already talked about, do you guys remember when we did the standing, close their eyes, standing, then we had them stand on something that was like a foam pad with their eyes closed, then we had to differentiate between vision or vestibular system or proprioception? Do you guys want to do that again to make sure we have it?
Mm-hmm.
Okay, so you guys get this. So if I want to adjust him on the left, which way am I turning his head? To the left, same side, it's easy. So if I want to go left, I'm going to go fast left, I'm going to take a couple seconds to come back. Fast left, and come back. Okay? And then you can adjust them. You've got there's something called velocity storage, and you've got about, I wish Spencer was here, Spencer knows. I think it's like between 7 and 14 seconds of storage mechanism that it's firing in that cerebellum that you have to work with. So you can do actually a couple adjustments in that time that you stimulate it. So I'll probably do it 3 or 4 times, and then I do it. You can also put him in a chair, which we don't need to do right now. Thanks, Doc. Which we don't need to do right now, but you can also just get him to sit in a chair with his feet up so his feet aren't dragging. Get him to look at his own thumb, and then just spin him. And then do it a couple times, not to the point where he gets dizzy, just give him enough stimulation that he's turning left, and then adjust him. Especially if you like seated adjustments. So if you're like a Gonstead style person, perfect. Because he's already in a chair, so you spin, 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 boom. You know? Alright, so let's do this. Todd, come by one more time. Here's how you know. So we're looking at 3 different things. We're looking at proprioception, we're looking at vestibular, and we're looking at vision. Right, so let's say he's looking straight ahead. Actually, everybody grab a partner. Let's all do this one. I love this part because there's so many people that don't know each other in here. They kind of like have the awkward look over and be like, me? Her? Him? All right, so whoever's the patient, stand in front of the doctor. What's the number one rule about working with a patient when his eyes are about to be closed and you're testing balance?
Get ready to catch him.
Lay them out. No. Always make sure if they close their eyes and they're going to tank, you can catch them. Cool? Fair enough? So I know if Tyler, if I'm close enough to Tyler that as soon as he closes his eyes and he tanks, I can catch him. Maybe not like that. That was kind of a happy accident. Yeah. All right. So first things first. So we're going to make sure that he can stand. Feet together for me. And neutral, hands down by your sides. Okay, so your eyes are open first, right? Yeah. Okay, let's see how he does right here. Because now he's working with technically all three. He's got proprioception coming in, his eyes are open, and his vestibular system can be checked. If he starts to lean, all three will let him know that he's starting to go off center and he can come back, right? So let's just watch that and see if he starts to sway. Let's assume that he does start to sway. We know that something's wrong, right? All right. Let's say he's good, because right now all three work together. If his brain's pretty good, his brain, even if something's messed up, his brain can act like a lie detector and basically ignore the one that's wrong. Cool? So let's take away vision. So Tyler, close your eyes. And then observe his sweat. So what happens if he closes his eyes and he gets worse? Are his eyes good or bad?
Good.
Good. Why?
Yeah,
his eyes are compensating for something, right?
He's relying on his eyes.
Right. He's just compensating. Yeah, but all right. So because I don't know, I had to say that because the first time I learned that, I was thinking like, oh, if he closes his eyes are bad. But you guys are right. So he loses his ability to use his eyes to correct himself. It gets worse. All right. So now we know it's one of what? Vestibular or proprioception. All right. So then we put him on, which we don't have. We could actually use a seat cushion. Whatever, it's fine. So let's say we put him on a pad, like a 6-inch pad, and we get him to stand on that. Which sense are you taking away? Proprioception. It's too fast for you to basically go in and compare what you're doing with actually what you want to do, so your brain can't use it. Okay? So what's the only thing left? Vestibular. So if you put him on a pad with his eyes closed and he starts to go crazy, you know it's vestibular, right? Okay. All right, so you guys try it. So everybody do doctor-patient, do standing eyes open, standing eyes closed. And then since we don't do perturbation, here's what we'll do. We'll do standing eyes open straight, standing eyes open with your head to the left, to the right, chin down and chin up. And then the same exact thing with your eyes closed, up, down, left, and right. Okay? What's up? I wish I had a picture of it. It's a square foam pad, and it's about 4 to 6 inches deep with a big square and a target in the middle. And you can use almost anything you want. So where you stand in the middle of it, it's just like you standing on like a more like a pillow. It's just foam. So think of like a big foam pad. It's not like springy. You're just kind of like lost in it. You know what I mean? So what's up, Matt?
Why you have him turn the head with the eyes open? Is that good?
Okay, so if you turn your head, if I go left, what vestibular system am I activating? Left. The way it's set up, you've got those 3 semicircular canals that are opposite to each other, right? So if I go left, remember those little hair things in that picture? If I go left, the hair in this one's going to be stimulated, but the other one's going to be inhibited because the way it's set up, it's in the opposite direction. So it's going to inhibit that hair and stimulate this one.
You want a quick motion to see if they sway? Or
it won't matter because you're still going to activate it just by turning it. So if you turn it and it goes like that, you'll know. So left, right, and then we'll talk about these. This is the anterior and posterior canals.
Feet close together, please. And keep your eyes open. Hands off to the side.
Okay.
The pads you were talking about, the whole purpose of it is just to make it where he can't rely on his feet to let him know where he is. So you're just trying to take stability out of his feet and ankles. So you can put it on a couple pillows, but they make like little thick pieces of foam. It's just to where you can't really like close your eyes and just be like, oh, I know exactly where I am just because of my feet.
Right. So what are we taking away here when he has his vision and we're turning his head side to side?
You're just more specifically checking each of the different canals, but you're checking them just in total, like using everything. If he's got his eyes open, you're just more specifically checking each canal at a time.
So then, what would it show if his head is rotated to the left or right?
Well,
here we go, right here. I think
if he rotates his head to the left,
I go vagal
then
really easy.
his
So what does that mean? If you get spun in the chair, you go
anterior
vagal.
canal on the left, because that's the one that's in that plane.
Okay.
It's rotating that plane.
Your
So
vestibular
that one's going to
system
be
is tied
active.
heavily, not
So
only
let's say
with
he had a crystal or
cerebellum,
something
but with
floating
your
around in
brainstem. Because your cerebellum works with your brainstem.
That would
Which is why if you
increase
spin
his
too much, you
swing.
get nauseous, right?
You can
That's
specify
vagal
where
nucleus
the
straight
problem
down,
is.
gag,
So
right?
if he's standing fine,
So you can use it lightly.
standing fine,
That's
he does
overstimulation.
standing fine,
If you're
he does
puking,
this,
you
and
just
he
crash,
starts losing
right?
balance,
But you
and
can
you're
use
looking
it
more at that
lightly
posterior canal.
in a certain direction that's there.
And then you
to
can do
rehab
that same
their
test
autonomics
with
as
eyes
well.
closed
Or not.
versus.
That makes sense.
You know what I mean?
So that would kind of.
I would, but I wouldn't do it a lot.
I would take that out of the picture. And you can also do the same thing with his head.
Yeah.
That takes what? Yeah.
So for
you're
her,
just
let's say it
you're
is.
just negating a couple of
Yeah.
to isolate individual.
That's too fast.
Because, like he was
That'll
saying, you're
make you
gonna
sick, right?
whichever one's best.
So show
like,
that
you have
speed
a really
again.
crappy vestibular system and a bad proprioceptive system. A lot of old people do.
So have you
They
had
like
that
pretty much
before?
use their vision
Or a dick
solely
pipe?
to keep them in balance. So when they close their eyes,
You might do that today.
the
You might try
other
to
two
fix you
systems
today
are
if you have
so
time.
diminished that they start losing their balance.
If you let's say you start
And
doing
then you
this.
can
Let's say
take
you start
away
swaying to the right.
proprioception, and if it gets even
What side would you
worse,
adjust them on
then
first?
you know that they're even using their proprioception.
I would adjust them on the right
So
first
their
to try to
vestibular
give them a little
system
bit
is
more
the worst
tone.
problem.
I would also try to
You
turn them
close
to
their
the right
eyes,
to give them
and it
that
gets
to
worse,
basically speed up
then you
that
have
side a
them
little
stand on
bit
a pad,
more
and it is about
to
the
see if you
same.
stabilize it.
Then
One of two things are gonna happen.
proprioception.
You either made them better,
Yeah, yeah.
You
or you just
kinda
made them worse, and you can
work
try it on the
through it.
other
It's like a
side,
puzzle
and then they'll
kind of.
plant and they'll stick it.
Take a little bit of practice.
You know what I mean?
The first adjustment would be
Yeah.
is that what you're
I do.
for the toe, right?
Yeah. So like for
Reasoning stuff.
so Tyler's got the right idea. I would start off super distally, and I'll just see if it'll get better or not. Is it? Can I boost that with a little bit of proprioception? Let's say I have a little bit less on that side. I go for an ankle. I do a pronation or supination protocol. I do a wrist protocol. I do whatever I want to do, and I just want to double check it. And if it's still worse, then I would add a little bit of vestibular input to it too. What I would do if I'm working on somebody with both, I would spin them first. When you spin, do you spin with a fixation or no fixation?
Fixation.
With a fixation, I would always do fixation. And if you do this, it's straight vestibular, and you're going to give them an ocular response and all that stuff. If you give them a fixation, it'll help them out. It'll make them less dizzy, because then your vision's not going with it. Your vision's staying still, and you're getting straight vestibular. I want you guys to watch a video real quick. So this is, well, I'll show it to you guys first, and then we'll talk about it. She's supposed to be staring at a dot. Okay, up and down. What do you guys see?
Do it one more time.
I'll do it one more time. I'll find my mouse.
Bounces around.
That's just vestibular firing too high. Okay, up and down. Okay, so I want to show you guys something. Actually, I would have a marker, but I don't. My bad. All right. So imagine this is the example I always use, and see if you guys can follow me. So imagine we've got cable going to somebody's house, and you don't want to buy cable, so you decide to steal their cable. So you go out, buy a splitter, and you basically make one cable, two cables, So theirs still goes to their house, and now you've got their cable. So they still pay for their cable, and you've got whatever cable they have. So whatever cable is coming from the main box is going to go to both houses, right? So I want you guys to think of that as the vestibular system, and I want you guys to think of that going to the eyes and going towards the spine. Because if I turn, I need to activate paraspinal muscles to stabilize wherever I'm going, and I need to activate my eyes to follow wherever I'm going, right? So it's basically the same exact signal going to two things. So if I see that the eyes are doing this, what do you guys think the paraspinal muscles are doing for your chiropractic patients? They're super jacked up. They're probably hypertonic, because what this is happening is as I turn my head right, my eyes are supposed to be going equally in opposite speed to the left. But if it's sending too much of a signal, they're going to go like maybe 2 times to the left when I only went 1 time to the right. And now they've got to catch up and they've got to come back. So each time they go off, your brain goes, and it corrects it. And it goes off and it corrects it, and off and corrects it, and off and corrects it. And it looks like that. So it goes click, 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 click. That's all the corrections. And then you go the other way. So you go left, your eyes go right, and it goes too far right, and it goes back left. Too far right, back left. Too far right, back left. Does that make sense? So watch it one more time and think about that.
We need a slow motion.
I know. That was a good one.
Okay, up and down.
Okay. Same thing can happen if you do up and down. So here we go. So your vestibular system, this one's going to go up to your vision. These two are going to go down. And you've got 2 things that happen. You've got your cervical, they've measured them instead of just saying paraspinal muscles. They do it a lot cervically. So you people with like, upper cervical skills, right here. But you've also got, here's why that can help you, why you can go in and adjust, because you've got one that's going from here up to basically saying, so if this guy goes, we're spinning. Wait, are we spinning? And the guy goes, yeah, we're spinning. He goes, okay, cool. Boom. Does that make sense? So you can fix some of this stuff with chiropractic adjustments because you've got an afferent and an efferent. Okay? You've also got one that comes down not only to the cervical paraspinals, but you've got your leg extensors. Because if I'm starting to fall, I want to extend, I want to be here, I want to catch myself, so I want extensor tone. So flexor tone, extensor tone, right? So I want extensor tone. So people have really tight muscles, and they're always pulling muscles, and they can't, like, no matter how much they stretch, they're like, I have really crappy tone in my legs. Or I've got, let's say it's an angular, and I've got left anterior, they've got more on the right. They're like, I always get, and like no PT is going to catch that. You know what I mean? Like you're going to go and they're going to be like, yeah, I've been to like 18 different physical therapists because I always jack up the same exact leg. Every time I run out for a football, every time I, do a backhand in tennis, every time I do whatever. And I always hurt it, and I always stretch it, and it always comes back. You go, You know what I mean? What fires into that part that's always getting messed up? So you can go in and do some vestibular rehab on them. You can do vision rehab on them. You can see if you can fix it that's not just working on the muscle, that's doing exactly what the vestibular system is telling it to do. The muscle's not messed up. And people try to fix the muscle, and the muscle's like, I'm good. I just keep getting jacked up because that's what I'm getting told to do. You know what I mean? Okay.
Hey Jason, I have a cool.
For that, like if somebody keeps hurting their leg.
I'm about to show a video, and it's going to go through all of them. So I don't know if whoever's heard Dr. Brock speak before, but I'm about to show a video, and he's about to go through all of them. So you're about to find out real quick whether you guys want to start going to the seminars or not for the Carrick Institute, because he's a really good teacher. So he's basically going to say, if this one's too high, this one's too low, here's what we're going to do about it. So there's an Epley maneuver, there's a Dix Hall Pike maneuver, there's a barbecue roll for the horizontals, and then there's basically like a reverse Epley for the anterior canals. For each canal, you're going to figure out a way to test it, and if it's messed up, you're going to have a way to rehab it. And once you rehab it, then you can do a muscular test. You can do either an FMS if you're into that, you can do a palpation if you're into that, you can do whatever you want to do, and then you basically cleared the musculoskeletal system, or you've cleared everything else, so now that when you do rehab on a musculoskeletal system, it'll work, and it won't come back, right?
If you had a patient like that you're talking about, like the athlete with the hamstring,
Yeah.
and you just want to do a quick vestibular test on them, and you wanted to do the eyes open, the sway test, eyes open, then eyes closed, then on a pad, that whole thing, would you jump straight into checking the different with the head movements, or would you just do straight on one of each first, and then if you think there's a problem in one of the canals, then start checking the head movements?
The quick one, the quickest one that I know about is you're looking for the side that's plastic, or you're looking for the side that's firing too high. So I get them to stand there with their eyes closed, making sure I'm there, and I get them to look up and down 10 times as fast as they can. And I get them to open their eyes. And like 99% of the time, they're never straight ahead. They're always like off a little bit, and they open their eyes and they recorrect back to center, right? So if I know that their eyes came from a left position, that means their eyes are plastic left, which means the right vestibular system is firing too high, which is making his eyes go left, right? So I want to fire the left. Either I want to make this side go up or I want to bring that side down. Those are my two options. If I'm doing a right or a left anterior and know that their eyes are too far this way and they need to come down, it basically just gives you a direction of what to work with. So that's a really simple way. If you stand up and all right, so let's try that really quick. Everybody stand up, find your partner, get them to stand there, move your eyes up, down, up, down, up, down as fast as you can, and then just open them up. And then here's what you're not going to be able to notice that position. You're going to notice when they move back from a direction. Does that make sense? So watch for the eyes to basically redirect as soon as they open their eyes back to midline, and you know where they came from, and then and then tell me what vestibular nuclei came from.
Feet together still? Or?
Feet together.
Hey, you can talk about central and peripheral.
Yes.
Okay.
Just move your eyes, right? Not your head.
Just your eyes, yeah.
This way, so it's right.
So that would be down and out. That'd be an anterior. Down and out.
I went up and out. I came from down and up.
Yeah.
That would be an anterior.
That's right.
Yeah, I know.
I do.
Yeah.
Well, on the right, that means the left. On the right. So if he opened it down to the right and he directed him back up to the left.
So that means his left posterior is firing too high because he went this way. So if I have him like this, it's whatever one goes to midline. So his left posterior is firing too high, which has his eyes up here, and you're going to come back.
Oh, so you're talking about, when you're talking about left, but you're saying just the movement of his head. I think that he's there.
Exactly.
Okay. I get that now. I was thinking you were talking about the eyes itself, but it's okay. So if you're down to the right, that means you're thinking that you're here. Yeah.
What up, Turk?
So if there's little to no change whatsoever, you just say that there's no problem there vestibular, like,
If you have to go out and look for it,
yeah.
we can work on something else.
So it's usually like pronounced. Well, your first one was.
I don't really see it about 10 degrees, which isn't a lot. It's probably like from there to there.
Yeah.
It's not like, I mean, that would suck. If it's out here, they'll know about it.
Well, they've been falling down.
Right.
Okay, so.
Should I do it? I think they would say no.
Let me check.
You be the doctor. Have you been the doctor yet?
Yeah.
Okay. Yeah, I would chill on the other part for you.
So if it was simply that, like, you thought you could go here, that means there's one on the opposite side of which side?
Here's mine. Yes.
So it means
Okay, so if I'm falling back to the left, what's gonna fire? This is gonna be tight.
Right.
So right hip flexor. Okay, hey, let's talk about that really quick. So let's talk about what would be tight. Fair enough? Okay, so for eyes, we're gonna make like the devil horns, because this is like whatever one you go to midline with is the one you're gonna use. Okay? So if I have a right anterior firing too high, And then, so you got to do this to where your eyes are pointing straight ahead and your eyes don't, like your eyes fixate. So if my eyes are fixated on that trash can, and I do a right anterior, my eyes go up and to the right. If I do a left anterior canal, my eyes go up and to the left. Here's where it switches, because in the posterior canals, to bring this one to midline, I have to go the other way. So it goes left and down with a right posterior, and then if it's a left posterior, it's right and down. Does that make sense? So left anterior, left anterior, right anterior, right posterior, left posterior, and then you just got your left horizontal, right horizontal. It's just, that's the easy ones because their eyes just go left or right in the opposite direction. Okay, so let's talk about this. Out of anterior, horizontal, and posterior, which ones are the most lesions? So which ones will you see the most in your office?
Posterior.
Posterior, cool. So your eyes will be more high or more low? Low. Yeah, so it's probably going to be coming from, if you do that test, they're either going to be coming from the bottom corner of either side. Okay? So that's a posterior. So if I'm leaning back, let's say I'm doing let's say I'm falling, if my perceived verticality is falling back and to the left, what muscle is going to be tight?
Flexors on the right.
Right hip flexors, got to bring me back. Right? But if I go back to the right, my left hip flexor is going to be back. So what if I go forward? I'm going to have really bad extensor tone, right? Because I've got to bring me back here all day. Right? So if I go forward to the side, you're going to see this side get tight. So you just basically figure out whatever way I'm starting or I feel like I'm going, I've got to have tone to bring me back to center. So that part's easy. So that'll give you an idea of, because a lot of times it can be both, and your both extensors are going to be bad. That's possible. You know what I mean? They could both be firing too high or too low. You just look at it. Here's the other thing. So if somebody comes in your office and they're like, I don't feel steady. Right? What are we already thinking? Vestibular. What are the first questions you're going to ask them?
Does the room feel like you're steady?
Not yet. Second question.
Okay.
So they feel like they're unsteady. They're like, I don't have good balance. You know what I mean? I just don't feel like I'm steady. Yeah, rule those out. Because you don't want to if they've got their blood sugar's 350 and they're like, I don't feel right. You're like, vestibular lesion, you're not going to look so smart. So make sure that everything else is cleared and then say, okay, now I think it's vestibular. And then you're going to say, do you feel like you're spinning? So that's where Elizabeth was going with that.
I thought we got that.
Is you want to say, do you actually feel like you're spinning in a direction? Because sometimes they don't. Sometimes they feel like, no, I just feel like I'm outside of my body or something else. So for this, to say, do you actually feel like you're spinning? And they say, yes. Here's the most important part of that. Is, do you feel like you're spinning, or do you feel like the room is spinning around you? Because that'll give you basically your central lesion, if it's a central integration of the vestibular system, or a peripheral lesion, which is actually the vestibular system being messed up. If you feel like you're spinning, let's say I'm spinning to the left, and it won't stop. It's a central lesion of the left, horizontal canal. Because I'm spinning to the left. If it's a peripheral lesion, the actual vestibular system is messed up. But if it's the world spinning to the right, it's the same thing as me spinning to the left, right? So it's a peripheral lesion of the left if the world is spinning to the right. Did everybody catch that? Let me say it again. Okay, so if I'm spinning to the left, it's a central integration problem of where the vestibular nuclei, it's the vestibular nuclei, right? Because it's central. But if I feel like the world, and that's called egocentric, egotistical, I'm spinning, right? If I feel like the world is spinning, then you basically flip it to the side, because if I'm going left, it means the world's going to the right. So if the world is spinning to the right, it's still a left vestibular nuclei, or a vestibular system lesion. It's not the nuclei, it's actually the actual apparatus, the semicircular things, okay? Does that make sense? Did I confuse everybody? Raise your hand if you don't get it. Okay.
Jason, I have a question.
Yeah.
So earlier you were talking about vestibular weakness pushing your eyes, or vestibular lesion pushing your eyes a certain direction. Now, are you talking about something that's more or less active? So if you say you have a vestibular lesion, is that like it's not firing as much or it's firing too much? Because we were talking about the posterior lesion.
That's where you basically just broke it down to two options, because if me and you were playing tug of war and the flag went to your side, it's either because you're stronger or I'm weaker. And it sounds like the same thing, but like diagnostically, I would say you're either firing too high or I'm firing too low, because that's basically what the eyes are doing. Because the eyes should be even. If this one's firing the same as this one, they should be right where you want to be. But if this one's firing too high and this one's firing too low, or even if this one's firing high and this one's normal, it's still going to be tilted. Or if this one's firing normal and this one's firing too low, it's still going to be tilted that way. You know what I mean? So basically just broke it down to it's either firing. So you could try either one for a therapy. I don't know how to make it more complicated than that. I could either say I want to spin them to the weaker side, or I want to activate the weaker side, because one side's just completely revved up.
So you said that we would probably more frequently see posterior lesion.
Posterior canal lesion, yeah.
Okay, so that would basically they're too active. So one that's going to push our center of gravity forward and give us forward head posture things like that, right? Correct? Is that compensating, or because it feels like you're falling backwards if you're activating posterior lesion.
So you're going to be you're perceived back, so you're going to have a forward translation.
Right. Okay.
Yeah.
And then to correct that, you want to try to stimulate anterior canal to
Yeah, because then you're going to perceive them more back.
okay, suspend to the weak.
As far as I know, yeah. I would try, since we don't have something to spin you forward and back, I would just get them to put them here and spin them left, or spin them like if that's kind of more complicated. That's the kind of stuff that we were trying to do at Advanced Club while there was an Advanced Club, because that's a really good question and it's applicable and it's clinical, but that would be more complicated.
Yeah, so we don't have the gyroscope.
Right.
But if you use the chairs.
But for basic, for like 90% of the time, we would try to just do the simple left or right and see if it helped. For the more complicated cases, you would have to do that.
So if you were to start doing pursuits, sorry, last question.
No.
Start doing pursuits, they would have saccades, catches saccades, or they could have
Yep.
they could be hypermetric saccades. You just do catch saccades to the strong side. Correct. So say that you have a strong left horizontal canal, just trying to push.
Okay, so would you see it like this?
Yeah.
Why?
Because one canal has more tonic influence toward one direction, so when you try to go against that,
I would flip it. I would leave this here, and I would do this, because that's going to bring out the vestibular lesion, because you're moving your head. With this one, you're not.
okay.
So Tyler was talking about the pursuits and the saccade. So if your head's still, and this is presumably firing a little bit, at rest, and you're doing this, you might not see as much. You totally might. It might be smaller, but if you do this, when you're actually activating them even more, you're going to bring it out bad. And it'll be in the direction of whatever way you go. You know what I mean? So I'm going to the left, and it goes, well, bam! You're like, okay, it's left. Okay. Does anybody have any questions? I'm hoping this video is going to, it's Dr. Brock, he can explain things way better than I can, so I was trying to stay out of the complicated stuff and let him do it. Okay? Wow, that's it.
Maybe a clear debris out of one connect. It comes in, they have to do this. And we're going to stick them mainly down in the well position we're at. We're going to assume that that's what we're going to conclude based upon this okay? In other words, we're rolling out the neuronas, we're rolling out the facials. That's not
I'm just thinking.
right? I'll give you that clinical scenario tomorrow, and I'll show you exactly how we work through those. So right now, just realize that the direction I'm going is the assumption that this is a positional pathology, and we're going to work through each situation.
What's that?
Fair enough? Okay.